Intentionally, I think separated because it's a long, there's key things you have to know about asthma. So I just want to separate it. Asthma is notorious. It's part of the COPD, but it's not chronic. It's a reactive airway disease, I call it. It's a reactive. Something is happening, okay? You are not responding well to some allergies or something, we don't know, but something in the airway get into your airway and your body said, I don't want it. And then you start overreacting with it. Remember, these are smooth muscle around it. So these are all muscles that help the lung contract. So you keep on contracting and relaxing, contracting, relaxing. If there is inflammation there, they get mad and they secrete mucus, too much edema, and they block the lung and the airway. Remember, this is key. This is an respiratory problem, going out. So respiratory issue. That's why they have what? Respiratory wheezing. If you see an answer choice and it's an inspiratory wheezing for asthma, don't take it. This is expiratory. Inspiratory wheezing means you choking. When you choke, you have inspiratory wheezing. Asthma people, expiratory wheezing, out and wheezing. As the air coming out, it blocks, it collapses. They have expiratory wheezing. That is the key pathophysiology for this problem. It's expiratory. I keep on saying expiratory, and that is normal for them. Okay. In acute flare, like any other infection, well, they're going to have tachycardia. The respiratory rate is going to go up. They're going to wheeze. It's okay. Let them wheeze. They're going to use accessory muscle. These people, that is okay with them because that's the only way they can breathe. Okay. The SAT is going to get low. That's okay. Then that's when you come in. What do? Treat them. You treat them. But then when you're treating them, we'll talk about it, fam. I don't want to go there, but I just want to give you the basis. When you're treating them, remember that the wheezing never goes away. Still there. It just gets better. The wheezing just gets better. Any asthma patient with no wheezing is B sharp. That's omnia sign. I don't know if I'm spelling it right. That means that patient is tired now. When they come in, they are like full force. They're like trying to air anger, they wheezing nonstop. Like, okay, let me use my accessory muscle and get some air out and in, air out. That's why they look like that. When they get tired, they can't do that anymore. So when there is no wheezing, it means they're tired. And if they're tired, then the airway compromised. This is the silenced chest that they usually see in your question. So this is silent chest. The chest is silent. I don't hear any wheezing. So that is a priority patient you should see. You got to see that patient. Okay. And that is the key aspect I want to pay attention to, like everything about asthma patient. Then to treat them, that's where you go to the pharmacology. There's a question. Oh, okay, somebody's saying, okay. Now, to treat them, you can think about it, okay? There's a couple of things going on. You have the muscle, the trachea, basically, and there's inflammation, okay? And there's muscles there. So you have inflammation. So inflammation. And you have a collapsed airway. So something is constriction, broncho-constriction. So my management is to take care of the inflammation, open the constriction, and give them oxygen. So if I give you a sort of question, I say, hey, oxygen is for asthma. In acute asthma, is oxygen okay? Yes. Is steroid okay? Of course, steroid take care of the inflammation. It's a bronchodilator. Okay, yes. And there's two types of bronchodilator for asthma. There's an anticholinergic, which the anticholinergic affects the smooth muscles, okay? The smooth muscle, that's what they're going to open it out. And then we have the beta agonist. Okay, remember your lung, you have two lungs, okay? There's you have two lungs, one here, one here. So you have beta 2 receptors there. Beta 1, you have one heart. So you have B1 receptor. So your heart, maybe this is as B1 receptor. So we're looking for B2 receptor. So beta agonist that can dilate, open it out. Okay, it will open the lung and then the lung will be fine. So we need to give them that something that has a B2 receptor on it. And that's the pharmacology right there. So if you recognize the medication, you say, oh yeah, this is what he's doing. That's all. Okay. The key thing is think about it. So we'll go about the pharmacology. I just wanted the basics so that when you see them, oh, this is why this medication is there. The key thing is you have constriction, right? Bronchoconstriction. So where is it? I have bronchoconstriction. So all this is like blocking, right? The steroid that is going to take care of the inflammation, you need to get there. Steroid cannot get here if there is blockage. So what? You open before you give them the steroid. So we have to open it. We have to open the airway. So you give them something that will open the airway before the steroid. So I use the alphabet. So the anticholinergic, the A before the S. So they get a Albuterol or anticholinergic before steroids. They cannot use steroid. You can't use the inhaler steroid and think it will go there. It's blocked. I got to open it up. So that's why they have to have the inhaler first. Then you got to teach them. Sometimes they don't know, and they can ask you that. So A before the X. They need the A before the X so that things can go down and take care of it. Okay. We're still on the asthma. I'm just giving you the key stuff that they like to ask in question. I told you about this. There's a B2 receptor and a B1 receptor. We want something that can bind to B2 receptor. We have beta blockers. We need a beta agonist. So if you give somebody a beta blocker, it's going to block the B2 receptor. And so asthma patient may have hypertension. And so you got to think, you, the doctor or the nurse, you say, hey, if you have, what happens if you have hypertension and you have asthma, how can we deal with you? Well, we got to make sure I'm not going to give you a blocker that will block a B2. I'll give you a blocker that just block B1. Therefore, in a simple form, you give them balm, which is the best way to remove them. And so this is the beta blocker. You know, beta blocker have law at the end. So you give them bisoprolol, right? Ophthalitis, no. Bisoprolol. The A is atenolol, and the M is metoprolol. So if you see it in the question form and you say an asthma patient is taking one of this, it's okay. That's good. Yeah, you put your finger up. Yeah, that's fine. Those are selective. These are what we call selective agonists, or selective beta blockers. You see, they're selective. So they go to the B1 and leave the B2 alone. So an asthma patient can breathe normally. The bad ones are the propranolol. So they cannot take propranolol. So these are non-selective. Propranolol, or is the L, and nadolol. These are the two non-selective beta blockers that you shouldn't use them on them. Okay, so asthma patient is safe with the balm, but not the PA or whatever you want to call it, propranolol. So far as it doesn't have a ban in it, I'm not picking it as an answer choice. Okay, and then key facts. Okay, I'm not just like beating around the bush. Okay, so and then what I just remember is things they should avoid. Every asthma patient, there's some allergy reaction going on that we can't figure out. But these people can react with Motrin badly. So NSAID, they don't like NSAIDs. They develop nasal polyp, and that can worsen it. So if they give you a question, you see an asthma patient with NSAID, they should avoid it. Avoid it as much as possible. Okay. What else should they avoid? Did I tell you they're making any mucus? No, they're not making any mucus. So you cannot give them mucomist, which is breaking mucus. It worsening will lead to bronchospasm. So no acetyl cysteine. You should avoid it as much as possible. So those mucomists will make things difficult for them. It will worsen their. These are the things that is very difficult. That's why it's very difficult to treat these patients. There's so many things you have to know. But if you know all of them and say, oh, bring it on, ask my question, and then you can figure out, you can just like. And the best treatment, what do you guys think? Best treatment for asthma patient? Best is to avoid trigger. It's like myasthenia gravis or multiple sclerosis. Avoid trigger as much as possible. If there's allergies that you know, well, if it's summertime and you go out, you get sick, well, please don't go out then, you know, like you go out in the evening. So those are the most important thing. So somebody asks, how about oxygen and albuterol? I don't think they will confuse you with that. I mean, I don't think it matters. You give them oxygen. As soon as they show up, most of the time they get oxygen anyway. So oxygen can pass through easily. So that's fine. You can give them oxygen first. I'll give them oxygen, then we give them an inhaler. But the steroids need inhaler to go in before the X. So airway, oxygen support is fine. Let's see. Anything questions on that? Then I think we saw a question. Yeah, just occurred to me right now. Last time, oh no, it wasn't with you guys. If a patient comes in and they are in distress, okay, or they have signs of things that are not going well with them in the asthma, the best thing to do is let them use the, see which level are they in, okay? So they need to know how to, you need to figure out where they are, which color they are in, okay? So they have to, you have to test it and figure out where, which level they are in. Are they in the green zone, red zone? And if it's so, then you can figure out and help them with that. So let me see, I need to get some people in, sorry. So you let them use the peak flow, the peak flow meter. I got to clean this, okay. Let's see, I'm trying to leave it so that you can take picture, but you got to do your peak flow, okay? And a peak flow is like a tube, basically a tube. You give it to them. It has colors on it, okay, and they will be like maybe 80% here, and 70%, 50%. You know, there's red, green, and then yellow. Okay, red zone means they are in danger. Okay, that's like probably 40 to 50%, and 70 up to is usually yellow. Above that is green. He's just telling you how good is their asthma is controlled. If it's green, continue what you're doing. If yellow, tell your doctor to modify your diet, your medication. If it's red, treat them and send them to the emergency room right away. And that is how you do that, the peak flow. So you have to, that's how you can assess. The other thing they trick you is you blow out. Why? I told you asthma is expiratory wheezing. So you let them blow out using the peak flow, not in. You will not know their expiratory wheezing if you let them suck in. So blow out of the machine. And they don't touch there's the meter on it. It's like an incentive spirometer. There's something here like that when you blow, it moves the gauge and it tell you where you are. So they shouldn't do anything to it. Let it stay where it is. You give it to them and they blow out, because that's what the pathophysiology is, expiratory problem, and you can figure it out. Okay, the peak flow. Okay. Any question? Oh, shit. Okay, let's see. I think it's time for any question before I move to the
Just a quick one. I just want to be sure. So there was a point you said that when there is no wheezing, um,
Can you repeat the question a little bit?
so at some point you said that when there is no wheezing, like when the patient has no wheezing and you can't hear any sound in the chest, is that when you have like the acute stage of asthma?
Yeah, when there's no wheezing, that means they're about to collapse. Their airway is basically tired. They can, the lung, basically the airway is, they're going to have respiratory distress. The airway will collapse completely because they're not moving anything anymore. They're tired. So they
Okay.
shouldn't be having any silence check. They should be wheezing. Your job is to keep them wheezing. How about that? I will reframe like that. Asthma patient coming in distress, I will keep you wheezing. That means if you wheezing, that means air is passing through. If there's no wheezing, that means the airway is completely obstructed. I want to hear you wheezing. So you may sing to them, keep on wheezing. But if you stop wheezing, we are in trouble. So do as much as possible to wheeze. So, and when you treat them, they should still have wheezing. Otherwise, if you treat them and there's no wheezing, they stay tired. There's no asthma patient who doesn't wheeze, whether it's well controlled or not. They always wheeze. And that's what
Okay.
you got to pay attention to. Let me see. How is it? We already basically we already done most of them. So I told you about the structure and what is exactly is going on. You have the basically there's smooth muscles here that help with dilation and constriction. And so you have inflammatory problem, okay, and you have constriction problem. So you that is all your target. So you have inflammation and you get broncho constriction. That's all. So the second one, which is bronchoconstriction, is okay. We just want to open the lung, the air, the trachea and the bronchi. We want to open them up, right? So I told you about the B2 receptors. So you need a B2 agonist that will open the app. And the common one that we use is albuterol. Okay, this is the short-acting and beta agonist. They call it SABA. Basically, it's very quick. Act within 5 to 15 minutes, you're done. So because we are in emergency, we can't give you something that is long. So short-acting medication. So therefore, if it's a short-acting, it's a rescuer. That's why they call it rescue medication. Short-acting, it just rescue you from danger. You got to give them something that will rescue them from danger. So short-acting rescue medication. So that's what it does, right? Unfortunately, the beta agonists, it just basically, it does what it do. It go and bind to every beta receptor that is over there. That's why they have palpitation. So that is normal. Agitation, right? Or you can say tachycardia about that. That's normal for them. Don't worry. If they give you a patient who has albuterol and all of a sudden you seeing the patient and his heart rate is 110, you just wash your hands and say, I will see you back later. You'll be fine. That is that's normal. Tachycardia 110 after albuterol, you don't need to see that patient first. Patient has the tremor, okay, fine. The same thing. You stimulating the beta receptors. That's why they're doing that. If I'm stimulating you, think about it. People who take stimulants, what happened to them? Ephedrine and all those things, what happened? They can't sleep. Insomnia, you'll be like walking around all night and you can't sleep. Don't memorize these symptoms. Think about it. I'm stimulating you by the beta agonist. Yeah, you're not going to sleep. You'll be awake and pacing. You have a tremor, tachycardia, palpitation. They're all normal, right? Because of the stimulation of the beta receptors. Remember epinephrine. Let me take it there. Epi. Why do you have epi? When I give you epi, what happened to you? You have palpitation, tachycardia, you can have tremor, you can have insomnia. It's the same thing because they're stimulating the same receptors. And what else? These are stress hormones, epinephrine, okay? I'm trying to explain something to you. They are stress hormones. Stress hormones, what do? They increase your glucose. That's why. So that you can use it for energy. You know, you can run away from the snake. If you give somebody albuterol, the sugar goes up. Glucose goes up. And guess what? That's where they will trap you. A patient who has an asthma on albuterol and has diabetes, we got to modify their medication. These are clinical stuff. I want you guys to pay attention. That's how you think for your exams. Think clinically. You can't memorize everything, but think something that is relevant. Of course, do you think there's a bunch of patients who have asthma and they have diabetes? They have asthma, they have blood pressure problem. So you gotta like, oh, okay, clinical scenario. I got to know that. If I know that, because if they ask me, then I know it. I mean, it's like something you have to know. Then you connect it. Because he's going to increase your glucose. Therefore, if you have diabetes, I got to give you more medication. I got to make sure your metformin, I got to give you double dose so that because your sugar, it won't work. You see how you got to do that, right? And the last one is it causes hypokalemia. Most people don't know. So you got to be sharp about it. If they ask you that, Yeah, hypoclean. And we use it to treat, when I was in medical school, we use it all the time. Somebody who have hyperkalemia. So if you come in, I'm digressing, sorry. So hyper, is it? Hyper-K, the treatment is glucose, insulin, albuterol, K-acylate. I can't spell it, whatever. Yeah. What is that? K-acylate. I can, yeah, something like that. And if it doesn't work, they get dialysis. That's the treatment of it. So, these are the signs and symptoms of that. So there's none of them will worry me than hypokalemia. So if they've given you somebody with asthma, you treated them, all of a sudden they have palpitation, they have tachycardia, don't worry about it. The glucose go up, fine. If they give you hypokalemia, yeah, I'm worried about that patient. Okay, so that's that one. It's a beta agonist, rescuer, easy B. Short acting. His friend is Salmeterol. That's long acting. That one, it take a while to. It take a while to work. So they all have the last name Raw. Raw, not Law. Law is a blocker. Raw is a agonist. Okay, so this one is a long acting. Therefore, if I come in and I'm in distress, don't give it to them. So this is for long-term control. That's all I want to say about it. Okay, because it takes time. It takes like 10 to 15 minutes to work, and it can last for like 12 hours. So you don't need that. Right? Now, we're still working on a bronchodilation. Okay. There's a medication that you can use it in OB also. Okay. This is Terbutaline. So don't forget it. Connect them. It's also a bronchodilator. It comes in the oral form. This one is also long acting. So it's not a rescue, it's for maintenance, right? So the problem is all other medications treated for asthma, you got to know contraindication. That is the way I want you guys to remember this respiratory. Apart from albuterol, the other medication are so bad that you have to know contraindication and the side effect. Terbutaline, what happened? It's bad. Okay, it has a black box on it. Okay, it causes problem. It also increases your sugar, so it causes you diabetes. I mean, it increases your glucose. That's all I want you to pay attention to. It can also causes dysarrhythmia. And you guys know my favorite, which is common. Okay, all the anticholinergics, they have the last name opium or tropium. When you see them, you may not know them, but I want you to pay attention to this last name, tropium. They can give you so many of them. All you should be looking for, if we give you any medication you don't know, you see tropium, is an anticholinergic. This anticholinergic medication. And you already know the side effects. You already know that, right? So this one can be used in acute phase because it can be used, it get dilated quickly. Okay. So sometimes they get that, they get albuterol. These are all inhalers, okay, not oral form. They can use for initial treatment. We use as an inhaler. And the other one is it start with the T. I'll write it so that you Theophylline. They are all inhalers, and all it does is a bronchodilator. They dilate it, but they are anticholinergic. So you know the symptoms of anticholinergic. If I give this to you, well, you're going to have a dry mouth, right? Don't worry about it. But the patient needs to know that, right? They can't sweat, no sweat, right? They get constipated, right? Urinary retention, right? This should be something like you just come like that, so that in case you see in the subtle form, you say, oh, I know. So you have to be careful about it. So urine output is going to decrease and they get into trouble. And a glycoma is going to worsen your glycoma. So when they give it to you, you paying attention. And then in the subtle form, you don't even have to worry about it. All these anticholinergic symptoms. So, okay, dry mouth, no sweat, constriction, constipation, decreased urine output, and you take care. The opposite is cholinergic side effect. There's a question. Oh, okay. Right, and that's that one. Of course, there's the dangerous ones. Okay. Question, somebody have a question? We're still on this thing, the pharmacology for this. Remember, there's some, we don't use them often, but they're very important and I want you to know. We call them Methylxanthines, okay? An example is Theophylline. I know you guys know about it, Theophylline. It's a good medication, but it has so many side effects. So many side effects with a narrow therapeutic is 10 to 20. All the medication with the narrow therapeutic, you can see they are within 10 to 20, like phenytoin and other ones, 10 to 20 range. It's powerful. I'll give you some trick to remember it. Theophylline is the 3 C's side effect. 3 C's. 3 C's because it caused so many problems. And so they don't even teach you about the side effect. They teach you what you should worry about. You should avoid to causes the side effect because the side effect is so bad. They get seizures. So you want to, it causes arrhythmia. So the main side effect is cardiac issue, arrhythmia, okay? And seizure. So you want to prevent that. Because of that, you tell the patient, teaching, this is your starter question, teaching and education. If I put you on Theophylline, I don't want you to get cardiac arrhythmia or seizure. But what do I tell you to do that? Is the 3 C's. No Starbucks. Okay, you can't go there. Any caffeinated drinks? No. Sorry, man. You can't do that. H2 blockers? No. Salmeterol, especially. You can't take it. Okay? And the liver problem. So the last one is Cipro. You can't take ciprofloxacin. You can't take that. But they usually C4. The C4 is, I put the, after I do this and I had this last one, the C, it's hepatic toxicity. So if you, because it doesn't, I can't put cirrhosis, you know. What this means is you should not take any medication that will affect your liver. Otherwise, it will increase because the medication is broken, will destroyed by the liver. And therefore, if you take any medication that is affecting your liver, then what is going to happen? You have toxicity of theophylline. And therefore, common one people take all the time is acetaminophen. You tell them don't take it because then that is going to affect the liver. Okay, so liver disease. If they have a liver disease, you can't get it. So you can do 4 C's or 3 C's. Cimetidine, caffeine, Cipro, antibiotic, and a cirrhosis. You can put cirrhosis, but most people don't have cirrhosis. You don't want to take anything that affects your liver. What else? The most common one is alcohol. So I have another way of remembering, okay? You can do 3 C's and 2 A's. How about that? 3 C's and 2 A's. Acetaminophen and alcohol, you should avoid them. because they affect your liver. And the 3 C's are what you have here. So 3 C's and 2 A's is what you should avoid when you see Theophylline. Run away from it. No alcohol, no acetaminophen, no Cipro, no Salmeterol, and no caffeine. Okay, because I don't want you to have arrhythmia or seizure. Now, so those are I don't think there's any more dilator. These are what dilating. So when they give you answer choice and you're looking, you can pick them, okay? Because they're doing what we expect them. Now, you got to deal with the inflammation. So pharmacology is all pathophysiology. That is the best way to learn it. You can't memorize it. Know the problem and say, oh, this medication is used for this. Put them in the system. So inflammation, steroids are the best inflammation drugs you can have. So they are anti-inflammation. These will help with inflammation. So I'm not going to list them. There's a bunch of steroids. And the way you see them last name with son, okay? That's all cash sons. I mean, as soon as you see them, you know, they have these last names. There's a bunch of them. I'm not going to list them, but just look like the last name in the cell. These look like steroids. Son, Casson, Metason, you know, they always have that kind of last name. All they're doing is what? Taking care of the inflammation. But if I'm the examiner, I'm not going there. I'm trying to see if you really know your stuff. And when I give an asthma patient steroid, what do you think? I take you to endocrine. Here you go. And you have to figure out, hey, endocrine, why am I dealing with endocrine on an asthma patient? You see the question, you worry. It's like, why is the teacher, they're asking me about endocrine stuff? Yes, because when you put them on steroid, inhaled steroid, some people have oral and inhaled steroid. And get what? You make them cushingoid. Now they are cushingoid patient. It become a Cushing patient. And what features do they have? I don't even have to list it for you. You know that. Or the moon phase, hypertension. Okay, I'll do that. Hypertension. Okay, moon phase, right? Abdominal strain, right? Buffalo amp, you know. You just keep on, right? Asceticism, right? It's just like you don't have to memorize it, you know. You can just like figure it out, like, okay, yeah, overweight, obesity, you know, right? Fluid overloaded. You see what I'm doing? I don't have this written down. I'm just saying it in my head. Fluid overloaded, right? What else? Can think about like steroid, infection issue, right? Wound infection, right? We just keep on going and going. Glucose, you know, hyperglycemia, right? You keep on coming. All these things, you just osteoporosis. You see where we get into different things that, you know, is away. So that's how you study. So when you study, don't limit yourself. Okay, asthma is on steroid. Well, I kind of bring my endocrine that I know into the system, and then so that when they ask me, then you can teach them. Okay, don't stop taking your steroid. We got to taper you. Okay, because if I don't taper you, what happened? Adrenal crisis. Sorry, guys, we're doing endocrine right now. That's the way it goes. It's a system problem. Now they are in adrenal crisis, and you can know hypotensive. I'm not going to go there, but that's the way. Now they are in adrenal crisis or downhill. So they don't stop taking the steroid. They taper it slowly by the doctor direction. Think like that. Any question on that? Sorry, guys, I got to digress, but I think it's teaching moment, sport learning. Anything else?
Yes, I have a question, please.
So that is all you need to about the steroid. That's the way they will take you there. You just have to connect. That's why asthma is powerful problem, and it's a good board favorite because they can ask you so many questions and trick you. Not tricking you, but trying to like let you see if you can think. If they come in and you've tried everything and they're not getting better, they have a name for it. So asthma status asthmaticus. That's all. I mean, it's a fancy name, but basically you can reverse the problem. They're wheezing nonstop, and you may have to intubate them. They may need IV steroids. So asthma, it's status. If you see that, status asthmaticus, it means you cannot get them out of the danger zone. So they may need IV steroids. Most of these are oral steroid, inhaler, but if they can't get them, they need the IV steroid. They need to be intubated and taken care of. Otherwise, they're going to die. And that is asthma and pharm. Okay.